Hello and welcome. My name is Sam Boag. I'm a physiotherapist and a director on the board of PRACE, Professionals and Researchers in Early Childhood Intervention. Today I will be presenting on the research snapshot number 23. Talking scrubs, improving the health outcomes of patients with communication disability, a mixed method investigation of feasibility, effectiveness, and clinician-patient concordance. The authors Betty-Jean Maria Dee-Price, A. Kate Fairweather, Janet Kelly, Max Saul Price, Monica Welsh, Adrian Esterman, Carolyn Ellison, Josephine Thomas, and Elisha White. But before we begin, in the spirit of reconciliation, Tracy and I would like to acknowledge the traditional custodian of country throughout Australia and their connections to land, sea, and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So what do you need to know? People without recognized speech or written communication experience significant disadvantages in healthcare, including poorer health outcomes, longer hospital stays, higher rates of preventable harm, and reduced opportunity to provide informed consent. Despite efforts to integrate augmentative alternative communication, AAC, the first person voice of patients is not often prioritised. Communication frequently defaults to carers or clinician best guess, particularly during high-stakes diagnostic interactions. Clinicians also report low confidence when communicating with people with communication disability, which affects the diagnostic accuracy, engagement, and shared decision making. What is the research about? The Talking Scrubs project aims to embed and integrate visible communication supports into everyday clinical practice. It reimagines the clinical uniform as a communication tool. Scrubs tops or vests feature key communication icons that provide direct communication pathways that encourage clinicians to identify and adapt to individual communication methods and support consent and decision making. By embedding and integrating AAC into routine clinical practice instead of treating it as an add-on. The intervention was co-designed with individuals with communication disability, clinicians, and AAC experts to ensure safety, relevance, and practicality. What did the researchers do? This article reports findings on stages 1 to 3 of the Talking Scrubs research program and presents the protocol study plan for stage 4. So stage 1, they completed a national survey. 293 respondents, including 108 clinicians. 71% rated Talking Scrubs positively. 61% of clinicians reported communication difficulty as a serious patient safety concern. Stage 2, co-design, 24 stakeholders, including people with intellectual disability families and clinicians, developed safe use protocols, and refined the scrub design. They co-designed two communication self-efficacy tools, SED17 for clinicians and SECH17 for people with communication disability. Stage 3, validation and pilot. They validated the communication self-efficacy tools for clinicians and piloted the talking scrubs in healthcare settings and demonstrated feasibility and acceptability. Stage 4, the protocol describes a mixed method study that will be examining the evaluation of talking scrubs in real-world healthcare settings. The mixed method study will examine feasibility and acceptability, communication self-efficacy, diagnostic concordance, and performance of the communication tools. Study sites include the Women's and Children's Hospital in South Australia, Adelaide, and the Adelaide Healthcare numerous GP sites. The participants include children with or without communication disability, GPs, and clinicians involved in diagnosis. Youth co-researchers with disabilities will be contributing to the research. What did the researchers find? Findings from stage 1 to 3 show communication disability is widely recognised as a significant patient safety and equity issue in healthcare. Clinicians reported low confidence communicating with non-speaking patients. Stakeholders, including people with lived experience, strongly support embedding visible communication supports into routine practice. Co-design processes strengthened and improved acceptability, relevance, and safety protocols. Purpose-built communication self-efficacy tools, SECD17 and SECH17, were developed and validated. How can you use this research? Key clinical and early intervention insights from stage 1 to 3 include communication barriers create safety risks and limit participation. Measure clinician capability, not just knowledge. The talking scrubs developed tools and validated the tools SECD17 and SECH17 to assess communication self-efficacy where no matched instruments previously existed. Communication self-efficacy influences clinical behaviour, and this is supported by broader evidence that you can find in the references below. Embedded communication supports into routine practice encourage inclusive environments, reducing reliance on specialist-only solutions. Communication access is a shared responsibility of us all across healthcare, ECI, and education systems. So where to from here? Stage 4 will evaluate and determine the following. Does it increase communication self-efficacy for patients and clinicians? Does it enhance participation and informed consent during diagnostic interactions? And do the talking scrubs improve clinician-patient concordance? And can it be feasibly and sustainably implemented in healthcare setting? Stage 4 now includes children and youth co-researchers, enhancing alignment with the national best practice framework in early childhood intervention. About the researchers, Dr. Betty-Jean Maria Dee-Price and colleagues are researchers and clinicians with expertise in communication disability, healthcare safety, behaviour change, and implementation science. The interdisciplinary team includes co-investigators with lived experience of communication disability, specialists in speech pathology, medicine, health services research, and biostatistics. The Talking Scrubs project integrates lived experience, clinical practice, and research to develop scalable, evidence-informed communication interventions. If you would like further information, the citation is listed here, and references to other research relevant to this Talking Scrubs project are listed below. Thank you for your time and for listening. Hi everybody, thanks for joining today. I have the pleasure of having a chat to Dr. B.J. Price, who is an incredible researcher and very passionate about inclusion for people with disability and at Adelaide Uni. So it's my pleasure to introduce BJ. And we'll have some conversations about her amazing research that is in progress here in South Australia. So thank you, BJ, for joining us today. If you would like to just share with us a little bit about your experience and who you are, that would be great.
Thank you. Well, thank you very much, Sam. It's an absolute pleasure to be part of Pracy and to share a little bit about the project that I've been working with. So I am the chief researcher of a project called Talking Scrubs, which had its emergence in 2023 after coming back from the ISAC International Society of Augmentative and Alternative Communication Conference that was in Mexico, and just learning that there really hasn't been a lot of cultural shifting in the acceptance of AAC in health settings. While lots of work has been done in capacity building, lots of research by people like Bronwyn Hemsley pointing to the difference between people that can speak and can't in health settings. The culture really hasn't accepted AAC. Boards go missing, communication boards go missing in those settings, and people change and staff that have been trained move on, so it leaves a gap. So the Talking Scrubs project was around addressing that cultural problem by inviting the important role of the communication partner to take on board their role in communication and also at the same time try and disrupt that culture.
Fantastic. Yes, definitely a massive gap that we all see for sure, and a really exciting project that you're embarked on. And I guess just a couple of questions today, but while the stage 1 protocol is now being trialled, which is fantastic, what are your views on how this research can be implemented into practice?
So the research project, it's got 5 stages. So we did the survey, which was stage 1, and the focus group stage 2. But how we've integrated that practice translation is right from the very beginning. So that survey that we sent out nationally really asked invited stakeholders to come to us and to respond and really give us their view about even putting icons on scrubs, whether this is a good idea or not, what would be the concerns that they would have about this, and when it comes to language on the scrubs and the scrubs vest that's worn that provides more language icons, what sort of vocab needs to be included, what is the most crucial vocab, what colours, what designs, what type of icons. So the translation then was getting firstly the interest and involvement of clinicians, of people with lived experience, of administrators, of AAC experts, of speeches, all coming together on that survey. And then from there, inviting within the survey people to participate in focus groups nationally. And so we then ran a series of focus groups that ended up with, we had 32 people put up their hand to say they would want to be in focus groups. We ended up recruiting about 25 and ended up with a mainstay of 19, which included, again, a really nice diversity of people from health, speech pathologists, doctors, young people and older people with disability impairments. And so that process, and we also had people like the Director of Nursing in South Australia from the Nyland area. It's important to have them involved because when it comes to translating to practice, we've already got stakeholders that have got skin in the game. So and what we've done is now increased, so as we go through each of our stages, stage 3, which will test the scrubs at the REPAT Centre and the Careability team, we include, each of those stages will include more potential stakeholders, and as we provide evidence of the efficacy or that these scrubs actually work, then we hopefully will not have too much trouble translating it to a health system, because the health system is in fact already a partner.
Yeah, fantastic. And I think that's often hard, isn't it? But if people have, like you say, skin in the game, have actually seen it be implemented, then it's a lot easier to translate it into the everyday.
Absolutely. I think too many research projects that are done in isolation, that may be done just, constructed by professional researchers that don't involve the stakeholders to whom they are providing this information or product or outcome or deliverable for, I think is a mistake. So it really, I think the greatest strength of this project has been its co-design amongst all people, and it's not a co-design where it's done by research and expert health professionals bringing in people with lived experience as co-design. Everyone is co-design. So, and in fact, and my personal experiences being a parent of a young man with severe cerebral palsy and with communication disability, and he is a uni student at Adelaide Uni, diploma in health science, and also a co-investigator. So very quickly we ensured that co-investigators and associate investigators are also people with lived experience, alongside professors in medicine, professors in nursing, speech pathology, academics and practitioners, AAC experts. So we've got this kind of diverse, multidisciplinary, lived experience-led co-design, which aims to cover as many bases and many stakeholders and the best possible translation right from the beginning.
Yeah. And I love that, because the co-design, as you say, is it's the whole way through, not just a focus group and that's it. Yeah.
Correct. Absolutely correct.
And I guess we're both big thinkers, BJ. So what is your vision for the talking scrubs, assuming that stage 4 achieves the outcomes that you are expecting and hope? Where do you see this going, and what's the big vision for talking scrubs?
Great question, thank you. Yeah, in so we've got a slingshot grant to do the current study, which is stage 3. We've also got stage 4 funding, which is from the Channel 7 Children's Research Foundation to test it in with kids in hospitals and with GP settings. And they were really excited about the idea of testing it with not just kids with disability, but all kids, but then we really focusing, looking at that cohort of people, younger people that may have barriers, additional barriers to communication. So, and then the next stage would be, we're still seeking funding. We'll put in some grant applications hopefully soon to seek grants for adults. So what the vision is that at the moment, you can walk into the Royal Adelaide Hospital in South Australia, and on the front bench is this sign that says interpreter service. So if you can't speak English very well, you have the right within a very short period of time on that day to have an interpreter sent to you. The vision I have as we walk into any hospital in Australia, any major public hospital, and that next to that interpreter sign is also a statement about the right to access communication with people who can't speak. And then as you walk through, on each ward would be staff, clinical staff that have been trained and are wearing the scrubs. It may not mean that every person will be wearing scrubs and having every clinician. Maybe that they all love it and they do it, but at least in any section of any public hospital, whether it's you've come in and you need to keep yourself still, your mouth's full of blood, you've got the capacity to look at symbols that can give really critical information, or you're somebody with a significant disability that can, instead of having their health concerns deferred to the support worker that might have just started with them a week ago, or a parent, they can have a first-person communication and be able to use the scrubs to describe some important things like how they feel, what they need, the state of their mental health, those sorts of things, get that across to the clinician. So I imagine myself walking through and seeing up on the wall, together with rights and responsibilities, is the right to that first person voice alongside the right to make a complaint, the right to get good healthcare and all of the rest of it. That is clearly stated in there, and it's within the policies. I also expect to see annual reports that show a decrease in adverse events and preventable deaths of people which have been evidenced come alongside people with communication disability. So I've got a big vision, and that's not just my vision; it's shared by the whole team. And I haven't mentioned a team. It sounds like we're a one-man show. We're not. We've got an enormous body of support, which we're hoping to build. We need to build, but we've had a lot of contributors help us along the way, testing Aboriginal groups, looking at these symbols. We've co-designed these symbols, Lived Experience Australia, helping to build symbols that reflect really important information around mental health, language that hasn't been available through other AAC. And also we've been developing instruments that will help measure the communication self-efficacy of both clinicians and people with communication disability, so that they in talking with each other. So we can, right from when a clinician starts training, is being trained and prepared for their to be self-aware and to develop their communication self-efficacy with anyone that is not able to speak.
Fantastic, BJ. It sounds like an amazing vision. It sounds like an incredible project, and certainly something that we all know there is a need for more accessible communication in our health system. So Yeah, good luck with the project, and it can we share your website with the people watching this so that they can follow the project and where it's at.
Oh, that's fantastic. No,
Yeah.
that's great. And people can, Adelaide Uni were very generous. They set up that website for us. And well, for all of us, because Adelaide Uni is part of this now too. And so we really encourage people to write to us with questions, concerns, anything, because and anyone that might want to get involved in partnership with us as well. We really welcome that. Yeah.
Excellent. Awesome. Thank you for your time
Thanks
and
so much, Sam.